Herkese merhaba, ben Doktor Nukhet.
Hello to you all. My name is Dr. Nukhet Isiten. I would like to thank everyone who has been involved in the organization of this conference, and I would like to thank you for your patience. I would like to start with an anecdote. In 1990, when I first completed my specialization, I also went to the United States with a scholarship in the field of psychopharmacology, and in the clinic, pharmacologists were making visits, and I was working as an observer, and I thought that this was very utopic for Turkey. I thought that the Americans are always in a position to defend themselves, and that's what I thought back then when I was in the United States. But right now, in the university I'm working for and in its hospital, we are together with an associate professor in the field of pharmacology. So I see that it is not a utopic thing, and we are not that paranoid. It is a must for better clinical practices. And over time, I also had a change in my mind. And when the drug dosage is planned for children, we should not think that about them as minor adults. We also should think about the developmental levels of children, and both pharmacogenetics and pharmacodynamics should be taken into consideration, and their differences in those respects should be taken into consideration. In pediatrics, the children are divided into four: the infant, the baby, and the child and adolescent periods, and each period has its own peculiarities, as you all know. And today, in today's practice, the most challenging thing for us is that when the children are taking the drugs, one says, for example, risperidone has a very bad taste. This pill is very big, I cannot digest that. And I usually play games with them. For example, think about this pill as a ship, and it's going to be sailing in your mouth, and etc. So we're always having difficulty in persuading children to take certain drugs, and the families are asking a lot of questions about the side effects, for example. Is my child going to become immune or addicted to this drug, for example? As you all know, they have such some fears. They read different sources from the internet, or they act on the basis of hearsay. They hear certain things from their neighbors, from their relatives and friends, and therefore they come up with different questions. They are very right, because their children are precious to them, and a doctor comes along and gives a lot of drugs to this child, and after a while they see in the prescription, for example, this cannot be used in the children, and it says prescription which is specific to addictive substances, for example, and it causes many problems within the family. And of course, the duration of the disease, the age of the child, and the dosages that are available in the market are all confusing for them because of their use in the market as well. And when they read the prospectus, and they come up with different information, which will be even more confusing for them. The children have pharmacokinetic differences on the basis of absorption, on the basis of distribution within the body, on the basis of metabolism, or in the form of release, for example. Pharmacodynamic differences have two very important points. One of them is 5-HT, and the other is dopamine responses. As you know, 5-HT is a very important neurotransmitter which plays an important role in many psychiatric diseases, and its intensity and concentration in the brain is decreasing by age. So when we talk about dopamine in the infants, in the the newborns, with the newborns and with the adults, there are very significant differences, and especially in the central nervous system, especially with the conduct disorder and ADHD, for example, it has a very important relation with the neurological and psychiatric and other conditions. As I mentioned before, many drugs, even though they are not approved for infants and children, are used in a widespread fashion. Likewise, some drugs can be given to children at a higher dose than adults on the basis of weight. For example, phentonin and carbamazepine and clonazepam, for example. We see different drugs, clomipramine, for example. These are the drugs which are very much frequently used by the children. And in terms of their adverse effects, they may vary between individuals on different factors. Genetic polymorphism, for example, the age and the weight of the child, elimination, the eating habits, and also placebo effects and the way it is administered, or other environmental conditions like use of nicotine and other diseases and comorbidities, for example. From the pharmacogenetics perspective, a phenotype TDM is important. But the blood or the plasma drug level is very important for children as well. I don't know if you have watched it on the internet, but there is a child with ADHD. It's an obese child and a very fidgeting child, and the child says, "I'm not going to give my blood." This is of course for something else, but I can see the examples of this in my hospital very, very, very frequently, because the blood belongs to the child, the body belongs to the child, and I am a little bit scared when taking the blood. So metabolic changes in eating habits, and the body weight and analytic problems, and in our country, economic problems are very important as well. These are the problems that we encounter very frequently today in our country. However, there is one important factor which causes differences among individuals in terms of response to treatment, is the genetic factors. And the efficacy and toxicity of a drug may change between individuals, and the enzymes, transport proteins, and receptors and other drug targets are very much related with genetic polymorphism. Genetic polymorphism is that mutant or other genes are present in a rate of more than 1% in a population. Enzymes, receptor transport systems, and ion channels are the structures in this polymorphism. I would like to be fast because I would like to show you my own case series. In the pharmacogenetic area, the molecular studies are characterized by Stockholm P4502DG, and it started with the colonization and characterization of this, and until now more than 20 drug metabolizing enzymes have been defined. I'm very old, I'm a dinosaur, but it is even older than I am, and they are present since 1950s. And the better or the best studied one is NAT2 and proconamate, hydrazine, and sulfonamate breakdown. It has an important role in that. So this is a bimodal distribution. According to the races, it has some differences. It is 8% with the Japanese, in 75% with the Africans. In the Europeans, it's 60%, and Turkey is close to that area, and it is 57% for the Turkish people as low acetylizing agents. Let's talk about CYP2, and it has more role compared to NAT2, anti-rhythmics, anti-hypertensives, and beta blockers, and in the psychiatric drugs, approximately 60% is metabolized by this. And in our study, it is considered as fast, normal, intermediate, and slow metabolizers. And it is divided into 4 as such. In the European population, in the rate of 2 to 10%, CYP2DG is slow metabolizer is present. When it is slow, of course, it's going to accumulate in the body. There will be extended adverse effects and unwanted adverse effects and toxic effects. And in our population, the frequency of slow metabolizer is considered to be 3.4% in a study which was carried out in 1994. But in my case series, this was very significantly high. 2% is slow metabolizer and 8% is fast metabolizer. In total, it is 10%. In other words, 1 out of every 10 patient is a risky patient in terms of drug usage. They either use insufficient drug or they use unnecessarily low doses of drugs and medication, and they show certain adverse effects. In terms of slow metabolizers, there can be accumulation of drug in the blood, and in the fast ones, there can be insufficiency. For the patients, this is an economic loss and time loss. It is seen in every 1 patient in every 10 patients. So this is a loss from those perspectives. When we look at retrospective analysis, it is shown that genotyping is increasing the success of treatment. It is preventing adverse side effects, and it is decreasing cost of treatment. Therefore, while using the antipsychotics and while using the antidepressants or before that, CYP2DG phenotype should be determined, and it is important to do that, and this is proven by certain studies. In order to provide more clear results to patients, the blood or plasma drug level should be measured and the genotype should be demonstrated. And in that case, the families are convinced in a better way. Think about it this way. You may be the best doctor in the world, or you may be prescribing the best drug in the world. But if the child and the parents do not believe in that drug, then the information that you have and the best drug you will give is not going to be of use. Therefore, the family should trust you and the family should be persuaded. Therefore, until now, the try-failed method, which has been very extensively used until now, is a loss for treatment planning and an economic loss. Therefore, in the drug, when we have an insight about which tissues can be reached and about the toxic levels in the plasma, you should be informing the family and the patient. This is a 6 years old boy, and I don't know if you can read the name of the drug. It is risperidone. It is going to be given, and Concerta is going to be given on a daily basis. When we look at the plasma drug level, risperidone BQA is very little. It cannot be measured. It is point something. In other words, it is insufficient. But I was giving it at very low doses already. But the unexpected part is that Concerta, the lowest is 18. But 18 milligrams of Concerta is given, but blood level is around 30. I don't know, the therapeutic level is between 13 to 22. In other words, I'm giving this child an overdose drug. In other words, according to their family, I'm poisoning this child.
When you look at the reasons, you see that CYP2D6 might be a normal metabolizer, but CYP3A4, which means concerted one, can be metabolized by the slow metabolizer, and it's the child which can accumulate the drug in blood. When we look at the names of those drugs, we see this table. I did it by means of the computer. The first column, ladies and gentlemen, as you can see from this PowerPoint presentation, shows us CYP2D6. I mean 60 to 80% of our drugs are being metabolized by this. According to normal standards, normal metabolizers are ANs, which means they are green. And and I have more than 50 patients. More than 50 patients make a series of cases. The greens mean normal, the blues mean fast metabolizers, red means slow metabolizers. The ones shown in pink are intermediary metabolizers. The first 25 patients, the second 25 patients, you see the normals here, CYP2 in CYP2 D6, and this is the last part. The third column, I didn't show it a lot, it is CYP1 A2, that's another enzyme. As you can see here, normal metabolizers are actually very few in our society or in this specific series of mine. And I keep them the normal drug dose, as I know it from the books. If we look at the percentages, we see that there is a total of 50 cases, ages between 5 and 14, boys and girls mixed, by the way. Normal metabolizers for CYP2 D6 is for 40%. Intermediary metabolizers are also 40%. Slow metabolizers 10%. Fast metabolizers 10%. In that case, slow and intermediary metabolizers, if we add them on top of another 50%, are composed of children who have no normal metabolizers. In CYP3A4, things are a little bit more in line with the literature. The total CYP3A4 patients are 43, 85% of them are normal, no intermediary metabolizers, slow metabolizers 4%, and fast ones are 6%. Different ethnic groups or subgroups show that different pharmacogenetic changes occur while the drug treatment is being prepared. This should not be neglected. In different individuals, different side effects might be seen because the responses will be different. So coming up with this difference beforehand should require a proper planning, which is going to lead into the least amount of adverse effects. Drug metabolizing enzymes should be evaluated, gene polymorphisms should be established, and the side effect risk of the patients will be reduced in this way, and pharmacotherapy is going to be more successful. DNA-based pharmacokinetic tests being performed require the drug dose to be designed specifically for the individual. It will contribute to this, and as a result of this, more efficient education is going to be possible. I would like to say something else. Thank you very much for listening to my presentation, by the way, but I'm waiting for the discussion session. Though there are people who think that these are non-economical, I actually was thinking in the same way. Yes, it is almost 100 Turkish liras for one drug, 2 drugs, 200 liras. But the phenotyping can be done by 8-hour urine collection, and it costs even more expensive. But in that 50-patient group, no money was collected from them. They all participated voluntarily. When I do a loss-profit analysis, and I see that if the competition is going to go down, and if the treatment becomes more extensive, this might easily be a reliable way of treatment for all of us, and I think these tests are really prerequisites.